A comprehensive understanding of headache disorders is fundamental to effective clinical practice. This content provides a detailed exploration of headaches, with a particular focus on migraine, a specific type of primary headache disorder characterized by moderate to severe attacks and a distinct set of diagnostic criteria. The material delves into the pathophysiology of migraine, illustrating it as a complex neurovascular brain disorder involving the trigeminovascular system and various brain regions, alongside the crucial roles of neuropeptides such as calcitonin gene-related peptide and pituitary adenylate cyclase activating peptide and central sensitization. It differentiates migraine from other primary headache disorders, such as tension-type headache and trigeminal autonomic cephalalgias, and highlights the importance of excluding secondary causes of headache through careful evaluation of symptoms and medical history. Furthermore, the content details the clinical presentation of migraine, outlining its characteristic phases, premonitory, aura, headache, and postdrome, along with their associated symptoms. The diagnosis of migraine is emphasized as primarily clinical, relying on a thorough history and physical examination, with neuroimaging generally reserved for cases with red flags. Finally, it comprehensively covers the pharmacologic management of migraine, encompassing both acute and preventive strategies, including traditional analgesics, migraine-specific therapies like triptans, gepants, and ditans, and emerging treatments, all within a framework of individualized, multimodal, and patient-centered care. To enhance your learning experience and ensure a comprehensive understanding of headache disorders, particularly migraine, the following learning objectives have been developed. Upon completing this material, you should be able to differentiate between a general headache and migraine based on specific characteristics, associated symptoms, and classifications. You will be able to explain the complex neurovascular pathophysiology of migraine, including the roles of the trigeminovascular system, neuropeptides such as calcitonin gene-related peptide and pituitary adenylate cyclase activating polypeptide, as well as central sensitization and key brain regions such as the hypothalamus, thalamus, and cortex. Additionally, you will be able to distinguish migraine from other primary headache disorders like tension-type headache and trigeminal autonomic cephalalgias by analyzing their clinical features and underlying mechanisms. You should also be capable of identifying and evaluating symptoms and signs that serve as red flags, indicating the need to exclude secondary causes of headache. This includes understanding when neuroimaging and laboratory tests are necessary and when they are not routinely indicated. Furthermore, you will learn to describe the 4 characteristic phases of a migraine attack, which include the premonitory or prodromal phase, aura, headache, and postdrome, along with their associated symptoms. Applying the International Classification of Headache Disorders criteria for the clinical diagnosis of migraine with and without aura will be emphasized through thorough patient history and physical examination. The principles of pharmacological management for migraine will be discussed, highlighting personalized, multimodal, and patient-centered approaches. Strategies for acute migraine treatment include the use of non-opioid pain relievers such as acetaminophen and nonsteroidal anti-inflammatory drugs, including ketorolac and naproxen. You will also learn about ergot alkaloids, such as dihydroergotamine, their mechanisms, contraindications, and their reduced use in modern practice. The role and mechanisms of triptan medications like sumatriptan and rizatriptan will be explained, including their action as serotonin receptor agonists, different formulations, efficacy, and contraindications in patients with cardiovascular risks. Newer medications such as gepants and ditans will be discussed, focusing on their non-vasoconstrictive mechanisms and their use in patients who cannot take triptans. Additional therapies used for acute migraine relief include corticosteroids and antiemetics, like metoclopramide and prochlorperazine. Preventive pharmacologic treatments will also be covered, including established oral medications like beta blockers, antiepileptics, antidepressants, calcium channel blockers, and drugs that inhibit the renin-angiotensin system. Treatments such as onabotulinum toxin A and monoclonal antibodies targeting the calcitonin gene-related peptide pathway will be explained. Recognizing the clinical presentation and management considerations of medication overuse headache and refractory migraine will be emphasized, highlighting how these conditions differ from other types of headache. The general role of choanalgesic medications, such as anti-seizure drugs, antidepressants, topical agents, and skeletal muscle relaxants, especially in managing chronic and neuropathic pain, will be outlined. Finally, emerging and investigational treatments for migraine, including propofol, ketamine, medical cannabis, and psychedelics, will be considered for future therapies. The key difference between a headache and a migraine lies in their specific characteristics, associated symptoms, and classifications. A headache is a broad term used to describe pain or discomfort in the head or neck area. It is common, with approximately 90% of people experiencing a headache at some point in their lives. Headaches can be categorized as either primary or secondary. Primary headaches are not caused by any underlying medical condition, whereas secondary headaches result from another medical disorder. Besides migraines, which are a well-known type of primary headache, there are several other types of primary headaches. These include tension-type headaches and trigeminal autonomic cephalalgias, a group of disorders that includes cluster headaches. It is important to note that relief from headaches following the use of pain relievers alone cannot be used to distinguish between primary and secondary headache disorders. Migraine is a specific type of primary headache disorder characterized by attacks of moderate to severe headache. Studies have shown that migraine affects about 12% of the population and is considered the most disabling among primary headache disorders. Typical migraine attacks often include a range of premonitory and postdromal symptoms. While headache is a common symptom overall, migraine possesses a distinct set of diagnostic criteria. It is defined by specific qualities of pain, associated symptoms, duration, and a complex neurobiological mechanism. It is important to differentiate migraine from other primary headache disorders and secondary headaches by carefully evaluating the symptoms and medical history of the individual. Migraine is a common neurological disorder characterized by a complex neurobiology involving multiple areas and networks within both the central and peripheral nervous systems. It is understood as a disorder of sensory processing, with dysfunction of the trigeminovascular system playing a central role. The underlying cause often involves a genetic predisposition, which is typically combined with behavioral and environmental factors that alter sensory processing in the brain, leading to increased sensory sensitivity. Historically, migraine was primarily viewed as a vascular disorder, with the headache believed to be caused by dilation of blood vessels. However, this long-standing concept has been challenged by substantial scientific evidence. It is now widely accepted that blood vessel constriction is not a necessary mechanism for the effectiveness of migraine therapies. The trigeminovascular system is crucial in the pain experienced during a migraine. This system comprises peripheral nerve fibers from the trigeminal ganglion, which innervate the meninges and blood vessels within the brain. These fibers converge centrally in the trigeminocervical complex, a structure consisting of the spinal trigeminal nucleus caudalis and the upper cervical spinal cord. From this point, second-order neurons project upward to thalamocortical neurons and further extend their connections to key brain nuclei in the diencephalon and brainstem, including the locus coeruleus, the periaqueductal gray matter, and the hypothalamus. Activation of the trigeminovascular pain pathways is thought to mediate part of the qualities of migraine pain by the release of neuropeptides, such as calcitonin gene-related peptide and pituitary adenylate cyclase activating polypeptide at the level of the dura mater. Calcitonin gene-related peptide is widely expressed in both peripheral and central neurons and has potent dilator qualities. Its elevation in migraineurs has been linked to a decrease in descending inhibitory mechanisms, which in turn might lead to migraine susceptibility through sensitization of multiple central neuronal circuits. Pituitary adenylate cyclase activating polypeptide can also provoke migraine attacks in susceptible persons, suggesting a causative role. While neurogenic inflammation in the periphery was initially proposed as the generator of migraine pain, blockers of plasma protein extravasation have failed to treat migraine in clinical trials. Direct evidence for a dural inflammatory component in migraine is lacking. However, peripheral trigeminovascular neurons may become sensitized and subsequently sensitize second-order neurons in the trigeminal nucleus caudalis and upper cervical spinal cord, projecting rostrally to thalamic nuclei and key medullary, brainstem, and diencephalic regions. Central sensitization of the trigeminovascular system, particularly in the trigeminal nucleus caudalis, plays a significant role in the development of chronic migraine. This sensitization can lead to a brain state characterized by increased spontaneous neural activity and lower activation thresholds. As a result, individuals may experience hypersensitivity to stimuli, diminished nociceptive inhibition, and expanded nociceptive receptive fields. The thalamus is also essential in the development of central sensitization, as well as in symptoms such as sensitivity to light and pain from normally non-painful stimuli in migraine patients. Those suffering from chronic migraine often show heightened activation of ascending pathways involved in somatosensory processing and reduced activity in circuits responsible for top-down pain modulation. This pattern suggests dysfunction of the descending pain modulatory system between attacks and an amplification of pain processing mediated by the thalamus. The hypothalamus is regarded as a central facilitator of pain and is implicated in premonitory symptoms like yawning, thirst, and frequent urination. Functional neuroimaging studies have reinforced the role of the hypothalamus in initiating migraine episodes. Altered connectivity between the hypothalamus and brainstem regions, such as the spinal trigeminal nuclei and dorsal pons, has been observed during the period leading up to a migraine attack. Recent research indicates that changes in the connectivity of the hypothalamus with these regions and cortical areas are associated with the development of chronic migraine. Stress, which is a common trigger for migraines, can activate certain receptors on dopaminergic neurons in the tuberoinfundibular region. Activation of these receptors increases circulating prolactin levels, which may sensitize trigeminal nerve fibers involved in headache pain. The thalamus plays a critical role in processing sensory information. It receives inputs from the skin outside the skull and the dura mater through second-order neurons in the trigeminovascular pathway. The thalamus then relays this information to various parts of the cerebral cortex, which are involved in controlling autonomic functions, emotional responses, and cognitive processes. The synchronization between the thalamus and the cortex is influenced by neurotransmitters and neuropeptides in several brain regions, including the brainstem, the reticular nucleus of the thalamus, and the hypothalamus. The cerebral cortex is increasingly recognized as an important component in the initiation and manifestation of migraine. Structural and functional changes in key areas involved in pain perception have been observed in patients during and between migraine episodes. Cortical spreading depression, a transient wave of neuronal and glial depolarization, followed by dysfunction of the affected regions, forms the underlying mechanism of aura. This phenomenon can activate neurons involved in the trigeminovascular pathway. During a migraine attack, the networks in the cortex exhibit functional changes that reflect the cognitive, painful, and emotional symptoms experienced. Migraine often runs in families, suggesting that genetics play a role, although identifying specific genes has proven difficult. Population studies have identified numerous genetic variations associated with migraine. The condition is also linked to the release of various neurotransmitters and neuromodulators, including calcitonin gene-related peptide and pituitary adenylate cyclase activating polypeptide.